So good afternoon, good evening. I'd like to thank the course directors for having me here. Thank you. So the topic at task is cardiogenic shock, particularly mechanical circulatory support, options, indications, and outcomes. These are some of the sources I thought I cite, ACC, and AHA guidelines on both acute coronary syndrome and cardiogenic shock, recent review by Hogler TL from Germany on cardiogenic shock, and a good review on next generation of temporary mechanical circulatory support in high-risk PCI and cardiogenic shock. So this is an outline, early diagnosis and treatment of mechanical circulatory support, options and future direction, especially touching down on assessment of clinical progress and mechanical circulatory support size and flow. So the first question is, obviously, we're talking about mechanical circulatory support. Do we need MCS in patient with cardiogenic shock? And the answer simply is yes, because despite the progress we've made, still the mortality rate remains around 50%, one of the most deadliest cardiovascular outcome in our patients. Generally speaking, the shocks, most of the shocks are ischemic, and most of those ischemic are either ST elevation or some of them non-ST elevation myocardial infarction. This is representative of what is early diagnosis and too late. I think if we catch cardiogenic shock in early part of the course, we can make significant change, but obviously sometimes it's too late if it reaches the cardiometabolic and multi-organ failure. This is from American College of Cardiology overview on cardiogenic shock, emphasizing both SHARC classification with regard to symptoms and presentation and SCI staging. This is the SCI staging. We have reviewed multiple times. Most of the shock that we know is the stage C, but obviously there are patients who are at risk. The most recent intervention I did 5 nights ago at 2 o'clock in the morning, somebody with proximal LAD occlusion, not in classic shock, but definitely at risk for shock. This is second modulation, and the third version of this SCI shock will be coming soon. Obviously, with regard to mechanical circulatory support, there are a number of devices. I'll review it briefly, both with regard to ECMO, intra-aortic balloon pump, Impella, and tandem heart. Most of the percutaneous ones are Impella CP. I actually, for the first time, I have invited Dr. Moin Matik, our chief of cardiac surgery, who joined us a few months ago. He has significant experience with Impella 5, 5.5, and ECMO. So we're expanding on our expertise in taking care of these patients. And MCS availability, capability, expertise, and types are the main things that we have to consider when most of the data obviously are in Impella and some on ECMO. But always it depends on the phenotype. So we have to decide whether it is mostly left-sided, is it right-sided, or has pulmonary respiratory failure as well, because the decision on the device mostly depends on the phenotype of the patient. What data with regard to MCS, what works, what doesn't work? We know both intra-aortic balloon pump and ECMO, the way they were studied. Every time we have discussions, the way they were studied doesn't mean ECMO doesn't work, it doesn't mean balloon pump, at least the way they were studied in the respective clinical trial, they did not work. The only trials that so far has shown improvement in outcome in patients with cardiogenic shock is the DanGer Shock trial. Just as a review, the DanGer Shock trial was a very super selective patients, looked at patients who came with hypotensive and hypoperfusion with a lactate of greater than 2.5, but excluded any patient who had cardiac arrest, comatose, RV failure, and mechanical complication. So less than 20% of the patients that were screened were enrolled in this clinical trial. And it's very important to pay attention because it doesn't mean it does not apply to every patient. This is the primary endpoint of 6 months mortality. You see an absolute 13% reduction in patients who receive the microaxial flow or the Impella CP. Obviously, this comes at a cost, and I will review the cost in in a little bit, and the cost is the side effect, especially vascular complication. But the number needed to treat was 8, which is excellent for a clinical trial. This is a long-term result, so even up to 10 years, the result were still positive and an absolute 16% reduction. So at least in the patients' population that were studied, it worked. Cardiogenic shock care doesn't work without a team. This is a representative of National Cardiac Initiative, Innova. Any place that does a good job requires a dedicated shock team and shock protocol. One of the most important things is not using a mechanical circulatory support, but having a protocol to escalate. This is from ceramics data that was recently presented at SCAI. This is a specialized center in the US that not only have mechanical circulatory support, but they also have the capability to escalate. So if they use an Impella CP and patient is still not having optimal hemodynamics, then they would be escalating to 5.5. What are future direction cardiogenic shock? I want to touch base on 2 things. One, assessment of clinical progress. So obviously, some of the clinical progress can be objective. We have talked about door to balloon time in the past, door to support, the time that takes us to place the mechanical circulatory support. The most recent initiative from Society of Cardiovascular Angiography Intervention is DLC, door to lactate clearance. So because of hyperperfusion, lactate is high, and the most objective, one of the most objective way of knowing if we're going in the right direction is looking at the lactate, not an absolute value, but how is it clear, 10%, 20%, 15%, and that's how we would try to prevent getting into a cardiometabolic stage. This is from, again, SCI, door to lactate clearance. So the main message for this is frequent monitoring of lactate level, especially in shock stage C to E, and that means checking lactate every 2-3 hours and adjusting, escalating if the lactate clearance is not optimal. How about mechanical circulatory support size? So why do we need better mechanical circulatory support? I've titled this slide, Dangers of Danger Shock Trial, and this is significant limb ischemia and moderate to severe bleeding. So even though number needed to treat was 8, number needed to harm in this trial was 6. So we need to come up with devices that provide the same benefit, but doesn't come at the cost of the adverse vascular effect. This is a very good review of vascular complication that happens in patients with cardiogenic shock and acute limb ischemia. So the solution for reducing vascular complication is reducing the size of the mechanical circulatory support. And there are a number of devices that are either in trial, some have IDE, that's Impella ECP, which is a 9 French, even though once in the body it grows to 18 French. This Elevate from Magneto Medical, this is actually usually 8 French, but it grows to up to 30 French. So all these devices, there are only 5 of them now, they increase in size once they are in the body. So the vascular, they are expandable devices. That means the vascular complication should be much lower. This is a comparison of the Impella CP with ECP and Elevate. You see 14 French compared to 9 and 10 French. The cardiac output is as good or maybe even better with some devices. Obviously, Impella CP is approved, but Impella ECP and Elevate, either they are in investigational device exemption or in the form of investigation. So what is important in a patient with cardiogenic shock? How? Obviously, did not touch base, but patient selection, age, presence or absence of cardiac arrest, hypoxic brain injury, device, and loading and venting if we're using ECMO, revascularization strategy, and most important is the size of mechanical circulatory support, the flow it provides, the time which is before PCI, and objectively following these patients with door to lactate clearance. Thank you.
Much.